Hello students and welcome to this new session, and today we are going to take up hemolytic anemias. And the reason why I have taken up this chapter is because it's not just one of the differential diagnoses of anemias, but also some of the points which I'll be taking up in this lecture are very basic and to be remembered things by all of you, should not be forgotten because they're all concepts of your undergraduate level, and nobody is going to forgive you if you do not remember these concepts. At the same time, all of these things which I'm going to discuss in this class, they are nevertheless already taught to you, but very easily confusing stuff is going to be there, and you might get confused when your examiner will try to cross question you. So let's not waste any time. Let me begin with hemolytic anemias. As I always give you an outline of what I'm going to discuss here in this chapter, I'll tell you that I'm going to start with the causes of the hemolytic anemia. Then we're going to discuss about the kinds, the types of hemolytic anemia. That means, of course, amongst the causes, the various categories in which we can divide the causes. Then we'll talk about diagnosis, and as we run through the hemolytic anemia, I'll tell you the management. So towards the end, I do not have a separate area which is for the management of hemolytic anemia. I'll discuss it as I go, and most of them do not have a particular management. You have to involve a hematologist to help you out. So let me first start with the major causes. The major causes of hemolytic anemia, the most important being the autoimmune causes. For example, the cold agglutinin disease, paroxysmal cold hemoglobinuria. And as I go through it, I've written down the short forms because these will be coming again and again, and I cannot all the time write down the whole stuff. So warm autoimmune antibody hemagglutination. So these were autoimmune disorders, autoimmune causes. These cold antibodies, warm antibodies, of course autoimmune antibodies might just cause destruction of the RBCs, and that is why you have autoimmune causes. Now let's talk about congenital hemolytic anemias, which you should know: alpha thalassemia, beta thalassemia, pyruvate kinase disorder, sickle cell disease, G6PD deficiency, hereditary spherocytosis, elliptocytosis, stomatocytosis. These are the causes of congenital hemolytic anemias. You should know that. And of course, xerocytosis. Then amongst the acquired few, you have like DIC. Now, why am I specifically, see, now I've come back to this again. Why have I come back to though we've already discussed about DIC, but a little bit, it's intriguing to know a little more about, the basics of DIC. And you will definitely come across microangiopathic hemolytic anemias, which could be also a category of thrombotic microangiopathic hemolytic anemias. The only difference between this MAHA and TMA, that is thrombotic, is that thrombosis is also there, and because of thrombosis they become the vessels become microangiopathic, and that is the reason why there is hemolysis in that. So that means there is also platelet disorder. But over here, if you're talking just about MAHA, that is just micro, and the reason could be many. So as I go, I'll tell you about it. Then you have drug-induced hemolytic anemias, and then definitely acute and delayed hemolytic transfusion reactions. That also causes hemolysis. There might be so many other causes, but these are like, see, they're coming up. The other causes are coming up, like clostridial sepsis. Any kind of infection would lead to your hemolysis. Clostridium, malaria, babesia, they'll all cause hemolysis. Paroxysmal nocturnal hemoglobinuria, osmotic lysis from hypotonic solution, and prosthetic valves, aortic stenosis. The aortic stenosis and prosthetic valves, they give rise to a shearing effect on the RBCs. See, on the very outset, let me tell you one thing, and that is why this introduction is very important as I proceed on with this lecture. See, in RBC, usually the lifespan of the RBC is 120 days. And in that 120 days, the RBC should undergo a lot of, resilience to the trauma in many, manifested in various forms, passing through the small capillaries, passing through small and big arterioles, passing through, the speed might increase or decrease, as we say, they, in case of traffic there is bottlenecking, so sometimes there are thrombi on the way, there could be plaques, there could be thrombus, and it's going through the shearing force. Sometimes there is friction, sometimes there is direct trauma, sometimes there is narrowing of the arterioles or capillaries and all, and they have to modulate their size accordingly. If anything is to happen to the structure of the RBC, it will, instead of modulating its size and its it getting flexible and then going across, it just breaks. So basically the hemolysis is a combined effect of so many qualities, not just of the RBCs but also the path in which it is going. And of course, like I spoke about thrombotic microangiopathy, in which you have the thrombus being made inside the vasculature, and because of that bottlenecking, the RBCs, they lyse. Now there are different kinds of hemolysis. It could be intracorpuscular defect. That means the defect lies inside the RBCs. For example, all kind of hemoglobinopathies or RBC membrane defects, or maybe certain metabolic abnormalities inside the RBC like G6PD deficiency or pyruvate kinase defect. And then you have the extracorpuscular defects. That means there's nothing wrong with the RBC. It's absolutely fine. It's resilient as much as it can be, but the outward effects are so pronounced. It could be mechanical, like in case of aortic stenosis, or in case of prosthetic valves, that there is a lot of shearing damage. It could be immunological. The antibodies are there against the RBCs. They're sticking on. They're causing agglutination. They're causing hemolysis. How much can it take? Of course, infectious agents, they go and they reside inside the RBC. For example, malarial parasite, babesiosis, and they cause cellular damage. And then of course you have metabolic damage, free radicals, oxidative stress, and all these kind of things that cause the damage, and that is the extracorpuscular defect. Now when I'm talking about the second type, that is intravascular hemolysis and extravascular hemolysis, very important concept which I'd like to refresh in your mind, is about what happens when there is hemolysis. And there are so many effects which come, because when I'm going to talk about the diagnosis of hemolysis, that means what all tests would you order if you see a patient who's hemodynamically unstable. The hemoglobin is down and it's going down. Obviously you would want to search for the cause. That means there is some hemolysis. The urine is dark colored, the hemoglobin is going down, which you can see through the CBC, and peripheral smears at certain kinds of cells are seen. That means that there is something or the other happening inside the patient, and in that case, in that patient, you will go ahead with more diagnosis. So as you go ahead with more diagnosis, the basics of which you should know. This is what I'm trying to explain when I'm talking about the scene behind the tests which you order, why the tests come the way they do. So now intravascular hemolysis and extravascular hemolysis. Intravascular hemolysis, the hemolysis is taking place inside the blood vessels. So usually it happens when there is either an RBC structural damage, or definitely of course the autoimmune antibodies are circulating, the infectious agents are circulating inside the blood vessels, and as a result of which you are having the hemoglobin, it breaks down. When the hemoglobin it breaks down, there are so many things which happen. When the hemoglobin it breaks down because of whatever reasons, see over here, can you see this? This is the metabolism of what happens. When RBCs they break down because of hemolysis, the heme is released. Heme actually gets converted into biliverdin, okay, and that's a it's like an unconjugated form of unconjugated form, and it goes inside in the bloodstream. And here it's not shown, but I've written it down over here, that usually this biliverdin or the which hemoglobin that is actually released, it is removed by liver rapidly. And how? Because hemoglobin usually binds to haptoglobin, which is a proteinaceous molecule, and as a result of which the hemoglobin haptoglobin complex, this is removed by liver very rapidly. And when there is a lot of hemoglobin which is loose, easily circulating inside the blood, as a result because of the RBC damage. See, RBC got damaged, release hemoglobin in the blood, hemoglobin is not going to be found like that, it's going to combine with haptoglobin, and haptoglobin starts decreasing. Okay, haptoglobin starts circulating inside the blood, and it combines along with hemoglobin, and as a result of which, when you see the serum levels of haptoglobin, they decrease. Also, what happens is, when RBCs, when they break down, they release heme protein as well, which is one of the components. How hemoglobin is made is because heme combines with globulin. When they both separate, finally you have heme that gets converted into, let's say, unconjugated bilirubin. Okay, finally it gets converted to an unconjugated bilirubin, which is of course circulating inside the bloodstream along with some albumin, some proteinaceous molecule, which, when it goes inside the liver, forms a conjugated bilirubin. And this conjugated bilirubin, when it is excreted in the bile and it reaches the gut, so the gut bacteria, they make, out of this direct conjugated bilirubin, they make stercobilin, which is excreted in the feces, around 80% of which 18% is enterohepatic circulation, goes back in the body, and only 2% is excreted in the urine as urobilin. So the color of the urine, if it gets more darker, or it becomes a little more yellowish in the beginning and then of course dark, it is because some stress is there on the liver. As much as it's getting the unconjugated bilirubin, it's trying to conjugate it, and it's finally throwing it in the feces, in the urine, and as a result of which, you can find out, you can have a rough idea, that means it is getting overwhelmed because of so much bilirubin that it has to conjugate. And then there is one more chart which I'd like to show you over here, which is also very important, which the examiners can ask you if they really want to go there, but they can easily. I mean, if I am the examiner, I'll definitely love to explore this horizon. If the hemolytic anemia comes into in the viva, I would definitely take the candidate into this direction, to ask a little bit about jaundice. If the patient is the patient going to show jaundice to you or not? For example, if there's a patient which comes to you showing jaundice, what and how will you examine her? So there is a part over here which says, see, RBCs, they break down by the reticuloendothelial system, or by the the hemolysis going on, because of whatever reasons, it finally gets into, it releases its hemoglobin part, which the protoporphyrins finally make into, like we just studied before, bilirubin plus albumin. This is how they circulate in the body. This, when it goes inside the liver, gets conjugated, and once it gets conjugated, it is given in the bile, goes in the bile, in the gut, it gets, either goes back in the enterohepatic circulation, or it is secreted as stercobilin in the stool. Some of it, of course, is thrown in the urine as urobilinogen. Otherwise, it gets back in the. So if suppose something is wrong with the liver, more of unconjugated bilirubin is going to be there, or indirect bilirubin is going to be there. If something is wrong with the, if this duct is obstructed, more amount of conjugated bilirubin is going to be present, right? Because it gets thrown back, there is back surge in the blood. Okay, and if suppose this place is more, for example, lots and lots of hemoglobin is throwing heme inside the body, that means more amount of unconjugated bilirubin is going to be present in the body. And in the DD of jaundice, see, this is how it goes: the prehepatic, hepatic, and post-hepatic causes. So how would you know it is prehepatic? It is because mainly unconjugated hemoglobin is unconjugated bilirubin is going to be increased. And what could be the cause of prehepatic? Basically hemolysis, hemolytic anemias. It becomes very simple when you see this. If it is hepatocellular, there's some problem with the liver, well, unconjugated will also increase, conjugated will also increase. Basically, it's not working fine. So urine bilirubin is going to be present. In this case, in prehepatic, it's basically urine bilirubin is going to be absent. Why? Because there's so much to do by the liver, there's so much of bilirubin unconjugated is being circulated, that it's not necessary that liver will be able to metabolize all of it, right? So it's going to be secreted out, and urine bilirubin will be absent. Over here, it's going to be variable, the urine urobilinogen. But in case of obstructed, it's usually absent for the simple reason that at the place where the conjugated, bilirubin was being thrown inside the gut and the circulation, it's not getting that chance. So basically, mainly the conjugated bilirubin is back in the circulation because of backflow, not because it's getting absorbed. It's not getting absorbed, so obviously it will not go ahead with the gut or with the urine. Are you getting that? That is the point. So this is actually the difference. So basically in prehepatic, what are the causes? Prehepatic, that means before the liver. The reason for increasing in bilirubin are basically the causes in which there is more of hemolysis. For example, can you see over here? Can you see here? See, before it even enters the liver, if suppose this hemolysis increases, it will give rise to basically unconjugated bilirubin because of hemolysis. But if there is some problem with the liver, the kind of bilirubin that is going to increase in the body will be both conjugated and unconjugated. But if there is a post-hepatic disorder, that means basically I'm talking about obstruction in the form of whatever, stricture, stenosis, cancer, gallstones, whatever. Gallstones, I'm talking about common bile duct gallstones. What will it lead to? It will lead to conjugated hyperbilirubinemia. Reason being that liver is doing its job, but it's not going ahead. Because it's not going ahead, so which kind of bilirubin will not be seen? What kind of bilirubin will not be seen? The one which is excreted out in the stool and in the urine, because it's not going in the gut. So how will it show in the stool? It's not going in the gut, so how will it be reabsorbed or thrown in the urine? So urine and stool will not show the bilirubin it is supposed to show. See over here, it's going to be absent, markedly decreased, or even absent. I'm really sorry, this is not going. Yeah, see, urine urobilinogen absent or markedly decreased, and this is basically because of common duct stone, and this hepatocellular is usually because of some kind of hepatitis. So this was nothing, just brushing up. And because somewhere down the line you will also, when you're talking about the diagnosis of hemolysis or hemolytic anemia, you will talk about DCT and ICT. So I'm just trying to refresh these two tests. ICT you should know anyways, because you will be doing Rh negative antigen and the whole chapter on Rh negative immunization. And DCT you should know, because I'm just discussing right now about hemolysis and hemolytic anemias. So basically the whole difference between direct Coombs test and indirect Coombs test is that in direct Coombs test you're taking only one sample, and that is the patient's sample, and you're taking patient's blood over here. What you're doing is you're taking patient's blood, you're withdrawing the patient's blood, and to this blood you are adding Coombs reagent. Okay, in a nutshell I'm telling you. To this patient's blood, you're adding Coombs reagent, and you're seeing for any agglutination. I'll tell you about the the logic behind it little later. And what are you doing in indirect Coombs test is, now what you're doing is you're taking recipient's serum. Recipient serum, which is of course having whatever kind of antibodies there are, and to this recipient serum you're adding donor's blood sample. What are you checking over here? For agglutination again. But it will not agglutinate until unless you have bridging antibodies. That means to this mixture, to this recipients, you're adding the anti-human IgGs. That means you're adding the Coombs reagent. Now if there is agglutination, that means it is a positive result. Again, here also the agglutination was positive. Here also the agglutination was a positive result. Now, what is the gist or what is the funda behind this whole test? In direct Coombs test, what are you trying to see? Whether the RBCs are having some autoimmune antibodies. Only in that case, this direct Coombs test is going to be positive. That means here I'm talking about cold agglutinins, warm agglutinins, I'm talking about complement cascade, whatever it is, but it is stuck on to the RBCs and very much there in the plasma. So these antibodies which are stuck on to the RBCs, they are now, add to it the anti-human antibodies. That means basically Coombs reagent, and they stick on, they make this bridge between the two antibodies, and they cause clumping or agglutination. That is telling you a positive result. So full total, that means what? Positive test result of DCT means an autoimmune hemolytic anemia is there. There is a component of autoimmune hemolytic anemia. It is nothing but it's aiding the diagnosis. That's all. It will help. We'll need it when we'll talk about diagnosis. And of course, you know about ICT. The recipient serum, if it has antibodies against the RBCs of the donor semen, which will be enhanced by adding the Coombs reagent, it will give a positive test result. As simple as that. That means this recipient is not matching with the donor. Do not transfuse, otherwise she's going to have very bad acute hemolytic reactions. So watch out for that. So that was all about intravascular. Extravascular is going to go through the same route. The extravascular hemolysis, that means I'm talking about hemolysis occurring in the macrophages of the reticuloendothelial system, not occurring inside the intravascular area. Nevertheless, it's going through the same procedure. Hemoglobin, which is released, it is degraded into heme is degraded into biliverdin, iron, carbon monoxide. Carbon monoxide combines with hemoglobin, forms carboxyhemoglobin and gets expired out in inspiration expiration. Okay, iron that gets loose goes inside the bone marrow for further use, and biliverdin I have just spoken in length about. So next comes the most important thing which is to be discussed, which is the diagnosis and the management of the patient with suspected hemolytic anemia. Unexplained hemolytic anemia. First of all, tell me one thing, students. There are many patients who are born with sickle cell disease, thalassemia. Patients are born with pyruvate kinase disorder, G6PD deficiency, hereditary spherocytosis, leptocytosis. Do you really think they are emergency situations in which you need to do something right now? And what are you going to do for these patients? Right? So I'm not going to discuss about those cases over here. If you really want to find out the diagnosis, well, in that case, usually the diagnosis is already made by the time the patient comes to you. You are not a pediatrician here, you're a gynecologist. So mostly every patient who's coming to you, that they are either a diagnosed case of why there is a hemolytic anemia in this patient, in which case some hereditary disorder will be there, or the second situation, which is more difficult situation, will be that you diagnose that patient for hemolysis. But if you find the patient is undergoing hemolysis inside, you need to just assess whether this is a situation which is requiring urgent attention or not. And how will you find that out if this patient is having an acute hemolytic episode? By examining the patient for any hemodynamic instability, for active bleeding, for acute thrombosis. So if the patient is actively bleeding, there is hemodynamic instability, or there is some evidence of thrombosis, well, it's urgent. And of course, that lab test that you would want to go through over here is if there is any renal failure, because usually this is what happens when there is acute hemolysis, where the hemoglobin is going less than 7 or even below, that cannot be raised with transfusion. If you have sent a peripheral smear, or if somebody in the emergency department has CBC with peripheral smear and comes out to be schistocytes on blood smear, that means it's very categoric of hemolysis. So yes, if suppose all these things are yes, the patient needs immediate attention, the first thing you have to do is to involve a hematologist or at least a physician, because this is not a thing to be dealt with alone. Now, you have to possibly evaluate in this case for thrombotic microangiopathy, of which one of the form is DIC. There is thrombosis, there is microangiopathy, there is hemolysis, there is decreased platelet count. Because of that, there is more bleeding, and then there is more angiopathy. Do you understand that all these things, it goes into a vicious cycle? There is more thrombosis, so there is microangiopathy. There is hemolysis, obviously anemia. Anemia, there is continued thrombolysis, all the coagulation factors are decreasing. Anemia is there, so even more bleeding, and then again more of these. The vicious cycle goes on. In this case, the patient will not survive if you just timely do not control the situation. So there is a way to go about it. DIC, if you see my lecture on that, if you see my notes on that, you will be able to get the gist of how you should manage such a case. acute hemolytic transfusion reaction, again in a medical emergency, and rapid intravascular hemolysis. For whatever reasons, there is a sudden amount of hemolysis that can happen in preeclampsia, that can happen as a sequelae of preeclampsia, HELP, DIC. You've already read about them before. Second is, suppose the patient is not that bad in a bad situation, but did the patient receive a blood transfusion within the last 4 weeks? If the answer is yes, well, you have to now evaluate according to delayed hemolytic transfusion reactions. And again, now this is not your field basically, but nevertheless you can get a patient with that kind of a see, the only idea is for you to know this, that when you have to call what kind of help. In this case, this is not a situation which alone you can handle. But if it's suppose a sequelae of preeclampsia, well, you will be the first person to handle it. So we're going according to the causes. Then our common causes of autoimmune. See, if suppose the patient has not had a transfusion reaction, has not have any it's not a treatable cause which you can link with the recent things, then usually it is an autoimmune hemolytic anemia. Now, autoimmune hemolytic anemia usually are because of drug induced or because of some infections. Lesser, of course, causes could be hemoglobinopathies, membrane defects, PNH, most of which you know already. So basically the evaluation based on what? So you have to do what? Of course, you have to ask the history. You have to do a clear-cut examination for seeing the jaundice. If there is anemia, how much is the anemia? If there is any pedal edema, what is the color of urine? Whether it is coming out okay or not, whether urine is coming or not. If it is jaundice, then what part of the body, whether there is any edema associated with it. So that will be all in your examination. And of course, if the patient is having high BP, so you can associate it with various causes for hemolysis. The drug was given, any drug recently, any drug was given, or any infection has happened. If the infection has happened, whether she's having fever currently, how many episodes of fever, or any associated symptoms is she having. So this kind of the whole history you can tell. Blood smear, you will have to go for now. What all tests will you say? CBC, PS, not just PS for MP, but PS, peripheral smear. For what? Peripheral smear for the type of cells and for any parasitic organism. And DCT, of course, you have to order direct Coombs test to find out whether it is actually autoimmune. If there is obvious evidence of an inherited intracorpuscular cause, if yes, then of course again you have to call the hematologist and go ahead with it. But if there is a positive direct Coombs test, well, again there are associated conditions which are associated with positive Coombs test, autoimmune hemolytic. If there is a drug which you've given, then there is a way to go about it. But if there is an infection, you treat the infection. If there is a drug given, give the antidote, or sometimes even immunoglobulins, IVIG helps. Suppose there is a negative direct Coombs test, then you have to again start thinking based on peripheral smear. Okay, history examination will tell you, for example, if there is a new medication given, it's a drug induced. If there is a recent infection, it's an infection induced. If it has been lifelong anemia, well, you then you think about of course, thalassemia, sickling disease, or intracorpuscular effects. If there is splenomegaly, think about, congenital, infectious, or even neoplastic processes. If there is dark urine, you think about intravascular hemolysis, which is there in, so many disorders like paroxysmal nocturnal hemoglobinuria or hypotonic infusions. If there is a heart valve, trauma or causing some, some aortic stenosis is causing this, again you can have intravascular hemolysis, which will always show like dark urine or something. So there are many ways to branch out when you're having these kind of physical examination, like dark urine. You just have one thing in your mind, it could be one of the causes of intravascular disorders. Now, more important, which I wanted for you to see, is what happens when you see schistocytes on the in the peripheral smear. This is where you are needed, because here it's one of the causes of it is either thrombotic microangiopathic anemia and mostly DIC, which is your branch. Teardrop cells, well, there is bone marrow involvement. Something is wrong going on with the bone marrow. Consuming more, or some, like you have hypersplenism, in the same way there is bone marrow involvement. Maybe a carcinoma, yes. Spherocytes suggests autoimmune hemolysis. Elliptocytes, hereditary elliptocytosis or even myelodysplasia. Stomatocytes, hereditary stomatocytosis. Intracellular organisms, of course, babesia or malaria, and you have to treat accordingly. And I suppose there are ghost cells. Well, Clostridium is responsible for that because that usually gives rise to that ghost appearance. So when I'm talking about diagnosis here and itself, I'm talking about the management itself. I've not deliberately included management in hemolytic anemias because this is beyond the scope of even the postgraduate level. You have to involve, multi disciplinary team over here. You need to involve the physician, you need to involve the hematologist if he's available, because you alone cannot take care of hemolysis once that establishes. But nevertheless, when they come, you need to give them the report of all these things that I just spoke with you about. And that was the reason why. And your concepts should be clear, because when you discuss it with your physicians or hematologists, you should not be lagging behind. At the same time, your concepts should be absolutely sparkling clear about this concept. If you still have doubts, you can message me and I'll take more advanced lecture in it, or I might just take a portion of it and tell you in advance, in more depth, in more detail, to make you understand it better. But the concepts nevertheless need to be known by you.